Thank you so much, everyone, for joining. This is the third lecture that Dr. Desai is doing on behalf of WCVIS and part of his acute care series. He gave a lecture on arrhythmias, a lecture on obstructive shock and PE, and now this third lecture he's going to be doing is on focused cardiac ultrasound for the clinical VIR. So I'll let Dr. Desai introduce himself. Go ahead, Dr. Desai, whenever you're ready.
All right, sounds good. Thanks, Sejal. So thanks to you and thanks to WCVIS and thanks to Dr. V for being interested in this. My name's Khanant Desai. I'm one of the vascular IRs at Brigham and Women's in Boston. I did my training here, and then I also did my IR at UVA, which was phenomenal. And then I actually came back and I did a critical care fellowship. I was the first one in the country to do something like that, and now I practice as both an IR and critical care physician. So as part of that, my passion, and if you guys know Dr. V, his passion is to bring IR into the clinical world. And so we're kind of joining forces on this series of lectures to talk about basic topics in acute patient care. So this is a really interesting one. It's not quite medicine-y. This is a little bit more like radiology, like you might be used to, but this is basically on echo. It's something that has obviously been the cardiologist domain for so long, but recently, with the advent of point of care ultrasound, meaning ultrasound machines being more available to everybody in the hospital, basically, everybody wants a piece. So you'll see nephrologists, critical care docs, emergency medicine docs, pulmonary, even GI. All these people want to get involved in using ultrasound because it's such a powerful tool. It's cheap, it's fast, there's no radiation, and it gives you physiologic data. And that physiologic data is what we really care about when we're talking about acute patient care. Non-procedural care for patients who are both in the hospital and also just in the peri-procedural period, when they have severe complications, reactions, when patients crash. You really need to know what to do, not just from a procedural standpoint, but from a medical management standpoint. And using the ultrasound to look at the heart is a crucial component of that. So, like I mentioned, POCUS has been exploding. And within POCUS, which is point of care ultrasound, is ultrasound of the heart. And if you've been around the hospital, done a critical care rotation, you might know that there's all these different protocols and acronyms for different exams that people do. So there's like the FAST, which most people are familiar with, which is the focus assessment with sonography and trauma. But then there's also RUSH, which is rapid ultrasound for shock and hypotension, FATE, focus, and even critical care echocardiography. So they're all kind of names for very similar things, which is not a full echo exam the way that a cardiologist would do it, right? A cardiologist would do it, hour-long exam, probably an outpatient. They're looking at all kinds of different measurements and different data to give a very complete picture. The important thing in what we're going to look at, and kind of mostly this focus and FATE and RUSH exam, is very quick examination to look at severe conditions that are going on with the patient. Basically, my patient's crashing. I don't know why. In addition to looking at the blood pressure and other vitals, I'm also going to quickly throw a probe on the patient's chest and take a look at the heart and see what it's doing. And looking at that is going to give you a lot of data. So what's an indication for doing the focus exam? Well, acute hypotension, like I mentioned, but even cardiac arrest. Unfortunately, we do see that as IRs, a patient coding on the table or in the peri-procedural period. But even chest pain, right? You do a procedure and afterwards, you're doing a post-procedure day one check and the patient has chest pain. It's good to just throw a probe on there. And then syncope, similar scenario. what are the conditions that we're looking for or the diseases that we're looking for, right? So you're really looking for ischemic LV or RV dysfunction, complications that can happen after an MI. So things like valve rupture and acute mitral regurgitation, things like that. Cardiomyopathies, right? So Takotsubo, dilated cardiomyopathy, hypertrophic cardiomyopathy, myocarditis, of course, with COVID, we treated so many COVID patients as IRs. So they can develop myocarditis that affects their heart function. Tamponade, of course, pulmonary embolism, of course, we deal with that all the time. And then hypovolemia or shock. You can have a septic patient, you can have a cardiogenic shock patient, all sorts of different patients in shock with hypovolemia, hemorrhage even, that we see all the time as IRs. So in order to understand what you're looking for on the focus exam, you have to know the hemodynamic basis of shock, right? So oxygen delivery, so shock is poor oxygen delivery to the organs. Oxygen delivery is equal to the oxygen carrying capacity of the blood times cardiac output. And so that cardiac output is really what we're assessing with our cardiac ultrasound. So the components of cardiac output are, of course, heart rate, which is easily assessed, and stroke volume. Stroke volume is composed or dependent on preload, which is basically the blood return to the right ventricle. And kind of a proxy for that is RV filling or distension. Afterload, which is the pressure that the heart is seeing to pump against. And then inotropy or contractility. And that's, again, another really easy thing to see on your ultrasound examination is how well is the ventricle squeezing. So, of course, these kind of four classic categories of shock, and each has its classic underlying pathophysiology, right? So hypovolemic shock, you're going to get poor RV filling, which leads to then poor LV filling, which then leads to low cardiac output. Distributive shock, something like sepsis or adrenal insufficiency or anaphylaxis, is going to lead to low systemic vascular resistance, which in late shock leads to poor RV filling because all of your blood is basically pooling in the periphery. Your RV is not going to fill as well. That's going to lead to your LV not filling as well, and then that's going to lead to low cardiac output. Cardiogenic shock is pretty self-explanatory, right? So impaired cardiac output through poor contractility. And then you get your obstructive variants, right? So pulmonary obstructive shock, really, massive PE or pulmonary hypertension, that causes high RV afterload, which then causes poor RV output and high RV distension. That RV distension basically impinges on the left ventricle, causing poor LV filling, and that causes low cardiac output. Okay. Whereas in tamponade, which is from a large pericardial effusion, you're going to get high biventricular afterload, which then leads to poor biventricular filling. The ventricles and the atria just can't fill because all this effusion is pressing down on them. And that also then leads to low cardiac output. So hopefully, knowing that pathophysiology, you can in your mind already start to imagine what am I going to see on echo to tell me which type of shock this patient has, okay? So when you're doing a cardiac ultrasound, there are certain variables that are basic that you really need to assess, right? So global LV systolic function, global RV systolic function, presence of a pericardial effusion, and is it causing tamponade physiology? You want to look at your intravascular volume and whether the patient is fluid responsive. And then, these last three are relatively self-explanatory if you're a good radiologist, right? So signs of pre-existing cardiac disease, meaning ventricular dilation, hypertrophy of the myocardium, atrial dilation, any gross valvular abnormalities. So if you see a vegetation sitting on a valve, or if there's wide open regurgitation, right, that can affect your hemodynamics and cause you to crash from a hemodynamic standpoint. And lastly, if there's a large intracardiac mass, if there's a large intracardiac thrombus, you should be able to pick that up on echo. So let's talk a little bit about the imaging protocol for echo. There's really 6 main views that you should get. And I'll stop here to say, if you guys are interested and want just a quick reference, go to this website, POCUS 101. It's where I took a lot of these pictures from. It's a great explanation. They have good videos and all that stuff. But anyways, there's 6 basic views, right? There's the parasternal long axis, parasternal short axis, apical 4-chamber, apical 5-chamber, subcostal 4-chamber, and subcostal IVC. To get all of those views, you're going to be having the patient basically in the same position, right? So just supine. This helps you sometimes get the heart closer to the chest wall, is left lateral decubitus positioning. Generally, you're going to be on, the patient's right side. You can also do this on the patient's left side, but important for you to be, ergonomically comfortable, because these can be slightly long examinations, 10 to 15 minutes. All right, so let's talk about the parasternal long axis view. So this is kind of your home view. Your probe is going to be positioned like this. It's going to be just lateral to the sternum, and it's kind of going to be in that 4th intercostal space. That's the textbook answer, but it can be anywhere, 3rd intercostal space, even lower down in the 5th. It really doesn't matter. But generally, you want that probe really centered in the middle of the left ventricle when you're looking at it longitudinally, to cut the left ventricle in perfect longitudinal axis. All right. So what does that mean? You're going to be taking your probe, and the indicator is going to be facing the patient's right shoulder. And so once you turn it towards the patient's right shoulder, you're going to get this view. And I hope you guys can see the actual cine clip of this. Can you? All right, awesome.
Yeah.
So the structures that you're going to see in this parasternal long axis view are of course, your left ventricle, right? So this gives you such a great view of the squeeze of the LV, but you're also going to see the RV here up top, close to the probe. You should be able to get the LA. And then lastly, the important thing is you're going to be able to see this left ventricular outflow tract, right? So the LV is pumping and blood's flowing this way through the aortic valve, out the outflow tract, okay? From that position, from the parasternal long axis position, you're going to turn your probe. So before the indicator was facing the patient's right shoulder, now you're going to just turn it so that's facing the patient's left shoulder. And what that's going to do is give you this short axis view. And this short axis view is great, again, for looking at the LV squeeze. But now it's getting even better to take a look at the RV, okay? So this is a normal view, but you'll see later on, if the RV is dilated, you'll see it pushing down on that interventricular septum, and you'll see the RV big and blown out, okay? Notably, in this parasternal short axis view, there's actually 3 different views that you can get, and they're all obtained by keeping the probe kind of in the same position, but tilting it either towards the head or towards the patient's, basically towards the LV apex, or more towards the patient's feet. So your home view, and the one that you were showing here, is the mid-papillary view, so that's right here. And again, that shows you the papillary muscles of the mitral valve, but also gives you the best view of the LV cavity. From there, if you tilt it a little bit upwards, you're going to get the fish mouth appearance of the mitral valve. So that gives you a good view of the mitral valve. And then you look even higher, or you tilt it even higher, and you're going to get the aortic valve in view. And that gives you the classic Mercedes-Benz view of the aortic valve. There's 3 leaflets. And so, if there's any gross pathologies, vegetations, anything like that, you should be able to catch it on that view. From there, we basically move the probe along the axis of the left ventricle all the way down to the apex of the left ventricle. And that's typically found in the mammary fold in women, or just below the nipple in men. And you're going to take that probe and keep the indicator facing the patient's left shoulder, but now you're really going to tilt it even more towards the head. And what that's going to do is going to give you, my favorite view is the apical 4-chamber, because it shows you all 4 chambers in really good detail. It takes some practice, to get this view, just like it takes practice for all the views. But if you can get it well, it gives you good functional assessment of the left ventricle, of the right ventricle, of the interventricular septum right here, of the mitral valve, of the tricuspid valve, and then also your atria, right? So if you're looking for filling of these chambers and dilation of these chambers, if you want to compare the RV to the LV, then this view is really great. From that view, what you're going to do is tilt the probe even more towards the head. And that's going to give you the apical 5 chamber. Now, of course, there's not 5 chambers in the heart. The 5th chamber really is just the left ventricular outflow tract and the aortic and the aorta. Okay. And this view is really good for just one thing, which I'll get into a little bit later, which is you're going to be able to get a velocity time integral of the flow through the left ventricular outflow tract. I'll talk about that in a bit, but that's important in calculating stroke volume. All right, so this view is not used that much. The 4 chamber is much more useful, but this is good if you're calculating cardiac output, basically. All right, and then you're going to get your subcostal 4 chamber view. So this is just another 4 chamber view, but if the apical 4 chamber is not good, then this one gives you another shot to look at the 4 chambers of the heart in one view. And so what you're going to do is you're going to take the probe, flatten it out, right? So that your indicator is going to be facing the patient's left chest wall, basically, and it's going to go real flat. And you're going to basically dig into the patient's subxiphoid region. It's going to be a little painful, but if you get a good view, you're going to get all 4 chambers. You're going to be able to see the pericardial space, and you're also going to be shooting through the liver a little bit. All right, so it gives you all the same data as a 4 chamber view. And then your last view is going to be subcostal IVC. So obviously this is not a view of the heart, but it is a view of the IVC. And that is important when we talk about intravascular fluid status assessment, which I'll get into in a bit. But essentially all you're doing here is getting a longitudinal view of the IVC. And you can see how it collapses with respiration. That'll become important in a bit. All right, so interpretation of the imaging. Now that you've gotten all of the views, what do you need to interpret? So these are the variables, again, that I want to just hammer in. You're going to look at your LV systolic function, your RV systolic function, presence of pericardial effusion, presence of tamponade physiology. Then you're going to look at your intravascular volume status and fluid responsiveness. And then you're going to look at your valves. You're going to look for masses, other things. But these are kind of the main things that you're looking at. So let's take those one by one. All right. So LV systolic function. Where is this seen? This is seen in your peristernal long axis, like I'm showing you here, but also your peristernal short axis, apical 4 chamber, apical 5 chamber, and your subcostal 4 chamber views. There's 2 ways to look at systolic function. Okay, number 1 is your qualitative assessment, and number 2 is quantitative. So by qualitative, I mean basically just looking at it, looking at it if it's squeezing well. You really want vigorous wall contraction. You want symmetrical wall contraction of the LV towards the center of the ventricle. One thing that people do is really just put a pen in the middle of their image, and they bisect the LV with that pen, and then the wall should be squeezing towards that pen symmetrically. All right. The second thing you can look at is strong anterior mitral valve leaflet motion towards the interventricular septum. All right. So that's this mitral valve, and you want to see this anterior leaflet really flap out towards the interventricular septum, and that indicates normal contractility. In this short axis view, you can look for fractional area change. And so basically, again, you're just looking for collapse of that chamber with every beat of the heart. On the short axis, the LV should really collapse if it's a good squeeze. You can also quantify stroke volume. And if you know your stroke volume, again, if you go back to that equation, if you know stroke volume, you're going to know what your cardiac output is, because cardiac output is heart rate times stroke volume. So stroke volume is equal to the left ventricular outflow tract diameter, which is obtained on your peristernal long axis view, which I'm marking right here. So literally, you're just getting your PLAX view, and then you're making a measurement in this LVOT, and you're multiplying that by the velocity time integral that's obtained on your apical 5 chamber view. So you're going to get your apical 5 chamber, and then you're going to turn on your pulsed wave Doppler, and then you're going to put the gate right on the LVOT. And that's going to give you a velocity tracing just like this. And there's a calculation, very easy calculation, that you just press a button on your ultrasound machine to calculate VTI, and it'll ask you to trace basically the waveform of systole once you've gotten this pulse wave Doppler. So you trace this waveform, it's going to spit out a calculation, and then you're going to multiply that by the LVOT diameter, and that is going to give you a stroke volume. And so low stroke volume obviously is concerning for poor cardiac output. High stroke volume, you can see that in cases of hyperdynamic flow, like in early sepsis or something like that. All right, so that's kind of global LV systolic function, but you also want to look for regional wall motion abnormalities, okay? So if you're seeing that the LV is not beating correctly in a vascular territory, you're going to immediately be thinking of a myocardial infarction, right? Or whether that's acute or whether that's chronic, you have to figure out based on the clinical status. But if the LV is globally dyskinetic or akinetic, then you're going to be thinking of something like a stress cardiomyopathy, so Takotsubo. But this is something that's, if you know your radiology and you're good at obtaining these views, it's not rocket science. You just take a look at the LV, check if it's beating well, check if there's regional wall motion abnormalities, and then you can do these calculations if you really want to quantify the cardiac output. All right, so this is a normal EF, right? So we're right now in our parasternal long axis view. And you can see, number one, that the mitral valve leaflet right here is flapping really well towards the interventricular septum. The LV is collapsing kind of symmetrically towards the middle of the cavity. And even the aortic valve is opening and closing normally. So that's a normal EF. This is, again, a normal EF on parasternal short axis view. So we've taken that probe, turned it basically 90 degrees, and now we're getting the LV in transverse plane. And you can see the papillary muscles here are collapsing towards the center of the cavity really well, and you're getting good squeeze. All right, so this, in contrast, this is postpartum cardiomyopathy, right? So you can see that, number one, the LV chamber is dilated, and that's because it's not emptying well. And then you can look at the interventricular septum. It's not collapsing towards the middle. And then the free wall is, again, not collapsing well towards the middle. So I would give this, if a normal EF is 55 to 70% on the last one, like this, I would give this EF, maybe moderately reduced to even severely reduced. So this EF is something like maybe even 30% or so. All right. Whereas this is a hyperdynamic state. So here we're looking at the EF in a apical four-chamber view. And you can see, number one, yes, it's beating very fast, but also these walls in the left ventricle are collapsing almost to each other. So they're almost collapsing the entire chamber. So that's a hyperdynamic state in something like sepsis. All right, so that's the LV. So let's move on to the RV. You can assess the RV typically on the parasternal short axis, the apical four-chamber, or the subcostal four-chamber views. You can, again, look at it qualitatively or quantitatively. So on the qualitative side of things, you're not looking for beating of the walls or collapse of the wall as much as you are in the LV. Here, you're looking for indirect signs. So what I mean by that is a poorly contractile right ventricle will become dilated. So you're looking for RV dilation. And then in turn, that RV dilation will lead to septal flattening. And so you're looking for RV dilation and septal flattening. Notably, the RV to LV ratio in your apical four-chamber view should be less than 1. Okay, so that's qualitative assessment. Quantitatively, you can also do other things to look for RV function. Okay, so the first of these is your TAPSE, which is your tricuspid annular plane systolic excursion. So what that is you take your in apical four-chamber view, you take your M mode imaging, and your M mode basically tells you the movement of a single structure or a single imaging plane over time. And so really what you're looking at is right here, basically where this tricuspid valve attaches to the free wall of the right ventricle, okay? And so all you're going to do is look for how much that moves over the course of the cardiac cycle. So that's kind of intuitive, right? If the tricuspid valve base moves more, then that means that the right ventricle is moving more, which means that it's moving, which means that the systolic function is good. If it's not moving as much up and down, then that means that systolic function is poor, all right? So a TAPC of less than 17, meaning what you do is you turn on your M mode and then you measure the peak and the trough and you subtract those two. And so if your TAPC is less than 17 centimeters, it means that the tricuspid valve is not moving as much. And that tells you that there's poor RV squeeze. All right. A second measurement that you can get is called your S prime velocity, and that is obtained again using not M mode, but pulsed wave Doppler. And you're again looking at the velocity waveform tracings, all right? So when you get your pulse wave Doppler gate, you put that on your tricuspid valve annular plane, and you're going to get your S prime wave, you're going to get your E prime wave, and your A prime wave. That's normal, all right? So what we're looking at is the S prime wave. And all you do is you look at the, you kind of measure the peak of the S prime velocity. And if the S prime velocity is less than 9.5 centimeters per second, that also indicates a weak RV squeeze. Basically, all that's telling you is that your tricuspid valve is moving at a very low velocity, lower than it should be in a normal RV. And so, of course, that means it's a weak RV squeeze. All right. And then kind of a third common thing that you're going to be looking for in the RV is something called McConnell sign. And so that is RV free wall akinesis with preserved apical contractility. And I'll show you what that looks at like in a little bit. But McConnell sign is kind of a classic sign for pulmonary embolism, massive PE causing RV failure, RV dysfunction. All right, so this is what it looks like when you measure your TAPC, right? And so this M mode gate is on the tricuspid valve where it meets the free wall. And so here they're doing the measurement. And so they're measuring the peak and trough, and then they're basically just subtracting that, and they're getting 15 centimeters. So what this tells you is that in this patient with pulmonary embolism, they have poor right ventricular systolic function. And so you can see how powerful this is, right? We know this patient has PE, but now we can also tell you that this patient has PE with RV strain because the RV is dysfunctional. And that puts them in the kind of intermediate to massive category of pulmonary embolism. And as an interventionalist, that might make you want to do intervention more so than in someone with normal right ventricular function. This is what just RV failure looks like, whether that's from, again, a massive PE or whether that's from an RV infarction or from pulmonary hypertension. You can see that the RV in this apical four-chamber view is just as big as the LV. That's not normal, right? You want it to be less than the size of the LV. So you can see that it's just as big, it's dilated. The right atrium here is very dilated. And of course, probably if we did a TAPC, this is not moving as well as it should. And then this is a McConnell sign. So you can again see the RV free wall is not moving as well. And then you kind of get motion of this apex of the RV more so than the free wall of the RV. And then in the parasternal short axis, this is where it becomes very powerful, we're looking, don't mind the pulse wave Doppler gate here, that's not important. What we're looking at is the dilation of the RV. So again, the RV is bigger than the LV. This is the donut view, and it's bigger than the LV. So that's already bad. But now you're also seeing flattening of the septum, right? You're seeing bouncing of the septum, and on systole, the septum is pushing into the LV. And so that's a really bad sign. What that tells you is that there's volume overload and pressure overload in the RV that's causing the LV to become collapsed. So that's late stage RV dysfunction causing LV dysfunction, which will then cause obstructive shock because the LV will not be able to pump out as well. All right, so the next thing that you're going to look for is pericardial effusion. And if you see a pericardial effusion, you're going to, of course, look for tamponade physiology. So we look for that in the parasternal long axis, apical four-chamber, and subcostal four-chamber views. This is an apical four-chamber view. So what is tamponade physiology, right? So, number one, you want to see an effusion. An effusion is small if it's less than 1 centimeter, moderate if it's 1 to 2 centimeters, or large if it's greater than 2 centimeters. But, I don't put a lot of stock into this. Really what I care about is it causing tamponade? You can look at the IVC, and if the IVC is very plethoric, meaning big and dilated, then that should put your antennae up that, okay, this is a very significant pericardial effusion that may be impinging on the cardiac chambers. Really, the signs that you're looking for are, number one, RA free wall collapse. If that's present in greater than a third of the cardiac cycle, then that's a sensitive but not specific sign. And then your money really is in RV diastolic collapse. So that's what I'm diagramming here. In diastole, right, if the RV is collapsing, basically that's telling you that the pressure of that pericardial effusion is overcoming the right ventricle, which really should be filling or should at least not be collapsing in diastole. If it's collapsing, that means there's a lot of pressure there in the pericardial space. And so that's a very sensitive and specific sign, okay? And then you can get something called echocardiographic pulsus paradoxus, which is exaggerated respiraphasic flow variation across the mitral valve. That's kind of an advanced topic, but basically what you're just doing is looking at flow across the mitral valve. So you basically put a pulse wave Doppler gate through the mitral valve. And if the flow is, if there's a lot of variation in the flow, then that tells you that there's concern for tamponade. But again, really what you're looking for is collapse of the RV and diastole and collapse of the RA free wall in greater than a third of the cardiac cycle. So this is what tamponade looks like. Note that there's a pretty big pericardial effusion. You can see that here in the pericardial space. The other things that you're seeing is RA collapse. Right there, you can see it's collapsing. And then, of course, you're seeing the RV collapse in diastole, right? So this is all of the signs of pericardial tamponade. And, you know, if you have a shocky patient and you see something like this is a diagnosis we can make, right? Right at the bedside. And so your antennae should go up. And if you're enough of a cowboy, you can even do a pericardial drain, right? I mean, we do drains all over the body. If you feel comfortable enough about it and the patient is decompensating to the point where you don't even have time to go and call cardiology, this is something that we can do as IRs, is drain this pericardial space using ultrasound. This is kind of a good distinction to make, right? How do you tell a pericardial effusion versus a pleural effusion? So this is on parasternal long axis view. You can see the pericardial space here, and then you can see the descending aorta. So if you see the descending aorta, any fluid behind that is going to be pleural fluid. So that's a pleural effusion versus in front of that or closer towards the probe is going to be pericardial effusion. So that's a good way to distinguish that. All right. That was a juicy topic. So kind of the last thing I'll talk about here is assessing your intravascular volume status. This becomes important if you're considering whether someone has hypovolemic shock or not, right? If someone's in hemorrhage, you want to know, are they in shock because they're dry? If someone's septic, have they dried out? And do you need to give them fluid? Is someone in cardiogenic shock and they're not dry from an intravascular standpoint? So this is a very classic assessment to make. You're going to be doing this primarily in your subcostal IVC view, but you'll also be assessing things like left ventricular or right ventricular filling on the parasternal long axis, short axis, and apical four-chamber views. Okay. So your subcostal IVC view, what you're going to do is longitudinal imaging of the intrahepatic IVC with measurement of the diameter of the IVC at its peak and trough during the respiratory cycle using M mode. So what happens, right, to the IVC when someone breathes? When you take a breath in, what happens is that your intravascular, in your intrathoracic volume drops. And when that pressure drops, And so when that pressure drops, the IVC empties into the heart. And so your intrahepatic IVC will collapse because all of that volume has now gone into the heart. Whereas when you take a breath out, your intrathoracic pressure increases. And when that increases, it kind of pushes back against the intrahepatic IVC. and the IVC does not empty as much, and so your IVC becomes plump. That's a normal variation that you're going to see in everybody. However, if you're dry, meaning if you have low intravascular volume status, that respirophasic variation is going to be exaggerated. That's the key, right? Is that everybody has this respiratory variation in their IVC diameter. But if someone is dry, that variation is going to be exaggerated. All right. So when you do these measurements, really as a rough guide, what you're looking for is if someone has a IVC that measures greater than 2.5 centimeters and does not collapse with respiration, then they are very intravascularly replete, meaning they probably have a very high CVP, and they do not need fluid. In fact, they might need diuresis if you're going to get them back on their Starling curve. The flip side of that is if they have an IVC that's less than 1.5 centimeters at its peak, and it collapses during respiration by greater than 50%, then that tells you that they're very dry, okay? And they could do with some fluid, they could maybe do with some blood, right? If this is a hemorrhagic shock patient, it really guides your therapy. And then, of course, you have things in between. Now, I'll say there's a huge caveat with this assessment because it hasn't been validated that well for everything in between here. And notably, there's things other than intravascular volume status that affect the IVC diameter, right? So you can imagine if someone has really bad tricuspid regurgitation, volume is going to be shooting back through the tricuspid valve, back into the RA, and then back into the IVC. And that's not a reflection of your intravascular volume status. That's just a reflection of valvular dysfunction causing more volume to shoot back into the IVC. Or if someone has constrictive pericarditis, right? Or heart failure. Let's say the RV is not pumping forward as well. That means the blood is backing up into the RA, backing up into the IVC, and making the IVC plump, not necessarily as a reflection of your intravascular volume status, but instead a reflection of your forward pump function. So you really have to be aware of, all of the other things going on with the patient before you make a treatment decision based on based on IVC diameter as a proxy for intravascular volume status. All right, so this is what the IVC will look like in someone who's purely hypovolemic, right? You can see with inspiration that IVC is completely collapsing down. So obviously that's a greater than 50% collapse over the course of the respiratory cycle, okay? As opposed to someone who perhaps, might be in heart failure, or someone who's just volume up, right? This is the IVC and it's not changing at all over the course of the respiratory cycle. And what's more is that you can see the hepatic vein, and even the hepatic vein is dilated. So this is someone who's very much fluid up, okay? In reality, you're not going to see these patients in real life. If you do, that's great. You can make a diagnosis right away. But in reality, you're going to see something in between that. So you really have to use your clinical judgment to guide therapy in these patients. All right. So I've shown you, the protocol for doing an echo or a bedside echo or a focused cardiac ultrasound. I've shown you the parameters that you're going to be measuring. And so now you just have to put it all together. That's the challenging part. And that's what takes experience. But hopefully, the last point I want to make is if you have a good understanding of the hemodynamics of shock and how they are all different with different etiologies, then you're already going to be primed to say, okay, what am I looking for on this echocardiogram to confirm my suspicion of what type of shock this patient has, okay? So going back to basics, again, what happens in hypovolemic shock, your RV is underfilled. And so your CVP is going to be low. That's your hemodynamic parameter. In distributive shock, your SVR is going to be low, which means that that's going to lead to blood pooling in the periphery. Your RV is going to be underfilled. All right. So your SVR is going to be low. And then eventually your CVP, which is a measure of RV filling and RA filling, is going to be low as well. All right. In cardiogenic shock, your cardiac index is going to be low because the heart is just not pumping well. And that's going to lead to actually fluid overload in the left ventricle. And so your wedge pressure is going to be elevated, and your right heart filling pressure, which is your CVP, is going to be elevated as well. In obstructive shock, your cardiac index, meaning your cardiac output, is going to be low for both of those. But in things like pulmonary embolism, your CVP will be high, but your LV filling will be low, right? Because the blood cannot get from the right ventricle into the left ventricle. Whereas in tamponade, your pressures are actually going to be elevated, but both ventricles are going to be underfilled. That's a key point, right? Because pressures can be up, but that's not necessarily a reflection of ventricular filling. And so, again, that's going to think about how that's going to show up on an echocardiogram, right? Your pressures might be elevated, for example, on a Swan measurement, but the ventricles themselves are going to be underfilled on your echo. All right, so finally, putting it together, what are your findings that you're going to see in these different patterns of disease? So in hypovolemic shock, because the RV is underfilled and your cardiac output is low, you're going to see a collapsing RV, a collapsing IVC, and perhaps an underfilled left ventricle. In distributive shock, so in early sepsis, for example, you're going to actually have preserved cardiac output. So your heart rate is going to increase to compensate for poor SVR, and you're actually going to get a hyperdynamic heart, if you remember what that looked like. However, in late septic shock, what's going to happen is that that blood is, again, going to pool in the periphery. It's not going to return to the right ventricle, and that's going to lead to poor LV filling. So you're going to get a collapsing right ventricle, collapsing IVC, and then finally an underfilled left ventricle, okay? In cardiogenic shock, which is a very broad category, you can get that from myocardial infarction, you can get that from Takotsubo cardiomyopathy, you can get that from valvular dysfunction, from arrhythmia. But what's common in all of those is that ventricular contractility is eventually impaired. And so this is where measuring your stroke volume, like I talked about, comes in handy. Or just basically looking at the ventricle, the left ventricle, in your long axis view, your short axis view, your apical four-chamber view. If that LV contractility is impaired, you really got to think about cardiogenic shock. Do I have an MI? Do I have cardiomyopathy going on? I'll tell you a real world example. I just had a patient. I was doing a complex iliocaval reconstruction on them. I ran an angiojet, and all of a sudden, anesthesiologist starts yelling, "This patient's about to code," right? So pressure is dropping, SATs are dropping, and we very quickly actually get anesthesia to come in and do a transesophageal echo while I'm doing a pulmonary angiogram to look for a massive PE, which didn't end up being there. The pulmonary angiogram was clean, but the echo showed an EF of 10% in this completely healthy outpatient. And so right there, I was able to diagnose that this patient had Takotsubo cardiomyopathy, stress cardiomyopathy, perhaps from an allergic reaction to the TPA, perhaps to a reaction to the anesthesia. But that was such a valuable echo to have, because otherwise I would be sitting there thinking, did I give this patient a PE? I'm working in the venous system, when in reality, it was actually stress cardiomyopathy. And then, of course, your two variations of obstructive shock. So a massive PE, just like I talked about, will give you a high RV afterload, which then leads to poor RV output, high RV distension, which then leads to poor LV filling and a poor cardiac output. So on echo, what's that going to look like? It's going to look like a dilated RV, decreased RV contractility. So your TAPSE will be low, your S prime will be low. And on peristernal short axis view, your septum is going to be flattening and bowing into the LV, right? That's what I mean by your RV bowing out or blowing out and pushing into the LV. So you're going to see it pushing into the LV, and then you're going to get a dilated IVC as well. As opposed to cardiac tamponade, you're going to get a large pericardial effusion, which is going to be collapsing and causing actually equalization of pressures in all of your cardiac chambers. And you're going to get that classic sign of RV collapse in diastole. All right, so that's your classic sign of pericardial tamponade. So I know that's a lot of information, and that's basically you're not taught any of this in medical school. You're not taught any of this in radiology residency. But hopefully, I've convinced you by showing all these examples that as an interventional radiologist, if you can just quickly throw a probe on a patient's chest, do these 4 or 5 views in the patient that's crashing, you can very quickly suss out, is my patient having an MI? Are they having a massive pulmonary embolism? Are they having pericardial tamponade? Or are they in septic shock? And that's an extremely valuable skill to have. I think it's something that all interventional radiologists should be able to do because honestly, we're all radiologists or had radiology training to begin with. And so this is not complex for us to do. We know ultrasound better than anybody in the hospital. And that's my soapbox. I hope you all kind of see the power of this. Happy to take any questions at this point. I'm happy to go back to any of these examples as well. Thanks for your attention.
Thank you so much, Dr. Desai. This was an awesome, awesome lecture. Austin had one question in the chat for how you ended up managing that patient with Takotsubo. And for anyone else who has questions, I'll keep the Zoom open for a couple of minutes afterwards, and you can stick around and continue to ask questions.
Yeah, that's well, I'll tell you, that was one of the most intense cases I've ever had. My immediate fear was that I had thrown a massive PE because again, I was working in the venous system. And so the first thing I did was to tell the anesthesiologist to start epinephrine and vasopressin, right? If the patient has an MI, that's not going to hurt them. But those two pressors in particular are very good for not causing pulmonary constriction, vasoconstriction. If you have a massive PE, you don't want to collapse your pulmonary vasculature, right? Because your right heart is already trying to push against a pulmonary embolism. You don't want to contribute to that by causing pulmonary vasoconstriction. And so you want to support the inotropy of the heart with epinephrine. And then the vasopressin also helps with that, but it does not constrict the pulmonary vasculature. I also started inhaled Velitri or epoprostenol, and that's a pulmonary vasodilator. And so that's kind of my go-to anytime I'm concerned for right heart failure, whether that's from a PE or not. Anytime I'm concerned about right heart failure, I kind of do those 3 things. And then after I got the echo results back and when my pulmonary angiogram was negative, then I started shifting my thinking to, okay, this is actually cardiogenic shock. And so cardiogenic shock is managed kind of differently, but epinephrine is still a great pressor, right? Because it has very good beta activity. In cardiogenic shock, particularly if you have global dysfunction of the ventricle, you just want to support the inotropy. And so epinephrine is great, but if you're feeling really adventurous, you can start a inodilator, right? So something like milrinone or dobutamine. Now you got to be really careful about those pressors because they are inodilators, meaning they do peripheral vasodilation in addition to inotropy. And so a lot of times when you turn these medications on, what happens is that their squeeze gets better, but they actually drop their pressures because you've dilated them peripherally so much. And so a lot of times what I like to do is start milrinone, and then I'll also start Levophed on top of that because the Levophed will counteract the alpha mediated vasodilation that happens in the periphery. And it also the inotrope will of course help my cardiac output. And so, yeah, I mean, that patient, we got them through the perioperative period, went up to the ICU, got them a cardiac cath just for fun. The cardiac cath was clean. And amazingly, this patient was about to code, and about 3 days later, as is normal with Takotsubo cardiomyopathy, had a complete recovery in EF, and the patient walked out of the hospital 3 days later. So very great illustration of how echo can be really useful in our practice.